wanted to just start us off with a conversation about what does GME look like here in California. So I'll provide a large overview before we get into the weeds of developing a residency program. And as many of you know, we have a primary care physician shortage here in California, and that's really what's driving a lot of these efforts to develop graduate medical education programs and partnerships across our state. So as you see here on the two ends of the room, there are graphs from newly released data. This specific chart here comes from a report that was released by the California Healthcare Foundation just in February, so a couple months ago. Shows that only one region in California meets the recommended primary care supply that they need for that region, which is about 60 to 80 primary care physicians per 100,000 population. And so the Greater Bay Area is the only one to meet that need. It's that first column here. It's on the light. Yeah, it's hard to see. I'm just on this side. So this one here, this is the recommended supply. As you can see, only the Greater Bay Area is meeting that. But as we all know, there are definitely pockets and populations within even the Greater Bay Area that don't have the healthcare access that they need and deserve. And so with that, you can see that there's a great need to really help train and develop more physicians so that we can meet the needs across the different regions of our state. The second column, which is this guy, this is the specialist column. Right here is the specialist. And as you can see, most of the regions here are either close or surpassing the physician, so the specialty physician requirement. This is taking into account access to underserved populations? This is looking at all populations globally, so it's looking at it by number of physicians per 100,000 population. Do you have the data segregated by underserved population? We don't. So this is a report published by the California Healthcare Foundation, and we can ask to see if they can break it down even further, but this is what was published in the report as of 2 months ago. But we can get back to you on that one in terms of can they break it down even further. Actually, they would, I think that they would have that data given the managed care issue throughout the state. I just don't see the numbers being real, given that you cannot get specialty providers to take Anthem Medi-Cal in our community, and that's we can. Yeah, and that's a common challenge for X2HC. You may have a specialist, may have them in your region, but whether that takes Medi-Cal is another story, especially if they're already full. Right. Okay. So, yeah, it's a challenge that folks get a lot. They may have enough specialists, but they may not be able to get them their patients seen by them. Okay.
What are you calling specialists in your area? What's the radius? I mean, like if you have to go 40 miles, 50 miles, 100 miles, what's the consideration? I don't understand.
For this data, last graph.
Yeah.
I'd have to go back and look at that report. We didn't necessarily work on that report. It was data that we found through the California Healthcare Foundation report that actually UCSF collected. So I can go back and get that information for you. I'll be offline about that. That'll take time. So the next slide, as you can see here, what it also shows is that we have an aging workforce. You'll see in this first one here, in the left-hand corner, this is looking at physicians in primary care, rating them out by their age distribution. And as you can see, 38% are 55 or older. So the folks that we expect to see retire soon. And so this is pretty concerning from the perspective of we not only have a shortage of those that are currently in practice now, a significant number of them will be retiring over the next several years. The other graph on the bottom right-hand side also shows that the physician workforce is not reflective of the California population. So this is another report actually published by USF, the Health Force Center, alongside Kaiser Minute as the funders, and we help contribute to this report specifically. But as you can see, about 4% of physicians are African American, and in terms of the California population, they make up about 6%. And then when we look at Latinos, about 9% of physicians are Latinos in primary care, but yet they make up about 38% of the entire population. So as you can see, there's some discrepancies. And as we think about increasing our workforce, it's very important to also think about how do we diversify our workforce so that they are reflective and representative of the California population. And this slide really shows you that even in all of the forecasted growth rates, we're looking at a 1% inflow growth rate, a 3%, and a 7%. In each of these different projections, we are still expected to see a decrease in our physician workforce, which is very concerning because what that also shows you is that we also don't have enough new physicians coming out and training and graduating from the residency program to replace those who will be aging out. So that coupled with the fact that we also need about 39,000 to 44,000 primary care clinicians, which is about a 12 to 15% above what we currently have. There is a very strong need to increase the physician workforce across our state. So as you can see, there are multiple states saying out. This is why we really need to increase the amount of residency programs that we have here in California to that is required. And so graduate medical education is part of the solution to increase access, to make sure that we are providing care at the right time, at the right place, the right person, all of that. And so one of the biggest reasons that we also push having more residency programs and partnerships in our health centers is because we also see a real success rate. This graph here shows you that California is leading compared to other states in terms of retention of California medical school and residency program graduates. So what this really tells you is residents who train here. So when you're looking at, I want to develop a residency program because I want to recruit and retain my trainees, the data is showing that they do. 70% of them stay, anywhere within the state. So we do find that they stay in the region in which they're trained. And many of you may be able to attest to that. But then as we look at residency programs a little bit holistically, especially as we compare primary care versus non-primary care in California, you can see that we're training a significantly higher amount of specialists. In other words, non-primary care folks compared to primary care. And the number of non-primary care residents has increased over the last several years compared to primary care has slightly decreased when you look at this chart comparing 1997 to 2012, which only contributes again to the need to really expand. And then as you look at this map, what this also shows you is that residency programs in California are clustered really in that greater Bay Area and the LA, Orange County area, and we have some along the Central Valley as well. But there's a lot of space in that map that is not yet filled, and those are the places that we need to develop new programs and also expand the residency programs that are currently in place across our state. What we're also seeing play out is, we're trying to understand where health residency programs are in California. What kind of institutions are training our residents. And so this data here is of, I believe, 2015. So we don't see health centers really captured in there quite yet. But what it does tell you so far is that public universities, in other words, like the UC system, they are training a majority of our residents here in California. That sort of last blue bar at the very bottom on the left-hand side tells you that about 50, they're training about approximately 50% of the residents here in California. And when you look at just primary care specialty programs here in California, what the graph on the right-hand side shows you is that most of those in primary care are family medicine and internal medicine residency programs. And that's sort of what we see play out as well in our existing community health center programs. Our teaching health centers have set up family medicine and internal medicine residency programs alongside psychiatry as well. So that's sort of what we're seeing play out here in our state. But as we sort of narrow it down a little bit further and look at community health center residency programs specifically, you'll see that we have 4 HRSA-funded teaching health centers where the health center is the sponsoring institution. And one health center, which, as Dr. Shannon mentioned, they formed a consortium alongside a university and also have a teaching health center grant. We have another teaching health center here in California, of the 6, but they are, I didn't count them in here because they're not within a health center. They're not affiliated with any health centers. They're in the dust. And I believe are also a consortium model, if I'm not mistaken. But as we begin to look at, sure.
Those other 6, are they're non-PhD?
Yes, that was good in there. Yep. These other ones that I have noted within the sponsoring institution box, these are 6 community health centers that are at this point in time seeking GME accreditation. Most of them have gone through and got their sponsoring institution accreditation, so at this point they're working on specialty or program accreditation. So I just have a question. What's the difference between the residency program site and the teaching health center? So the reason I noted them separately is because, as I mentioned at the top, they have a teaching health center grant. So the 6 I mentioned below, that the health center accreditation, they don't have a teaching health center grant at the current time. That's how I'm distinguishing them. What's the difference between the residency program and the teaching health center? How are they different? So, I mean, folks use the names interchangeably. I'm just using them here to distinguish who has a HRSA grant and who doesn't. But, like, with the hopefully new funding that we'll get through the teaching health center program through HRSA, they will also be able to obtain teaching health center grants.
So I'm going to jump in quickly with that. Think of Teaching Health Center as a funding stream. It is a grant. Okay. Now there's those who would argue differently with me on this, but think of it as a grant that comes from HRSA. That in order to qualify for that grant, you have to meet certain requirements, and those requirements are structural in many ways. Okay. But in the state of California, we have certain FQHCs that are funded by that grant. And then there's also the Song Brown program with Teaching Health Centers. And Melissa's going to talk about that later today. Okay, but it does get confusing because, yeah, it just does get confusing.
And apart from those who have sought GME accreditation, we also have a good number of community health centers across the state that are participating as a continuity clinic or rotation site. So just off of some informal studies that we've done at CPCA, we've presented about 26, but I'm pretty sure we're missing a couple. So in mind, that's sort of what we're seeing play out across the state so far. And that's where the participant surveys will also come in handy, to be honest with you, because we want to collect more of that data to be able to have a better understanding and be able to support you all. And in terms of GME opportunities, Kiki hinted at this already, but there are several funding streams at this point that have been established over the last couple of years to really support GME growth in community health centers. And so I'm not going to go too deep into this right now because we're going to have a whole session on this today. But do just want to point out that there's the HRSA Teaching Health Center program. We have the Tom Brown program, the CalMed Force program, which is also the Prop 56 program. And we have the PPS reimbursement, which we just finalized alongside DHCS through the state plan amendment a couple months ago. And what's really exciting is not only have we developed those funding streams over the last several years, but there continues to be more interest and more momentum in the GME space in California. And that in part is due to some of the work that the California Future Health Workforce Commission has done in creating a master plan for California to address its primary care, behavioral health, and geriatric challenges. And this report has a lot of stuff in it. There's a lot of great recommendations, but for today's purposes, we just want to highlight that there is one recommendation in there specifically. It's actually one of the top 10 that really focuses on expanding the number of primary care and psychiatry residency positions with the goal of increasing our physician workforce by about 1,800 primary care physicians and about 2,200 psychiatrists by 2030. It has a lot of really good recommendations about making sure we're making permanent the Tom Brown and the Prop 56 funding, that we secure funding specifically for teaching health centers as well, we create some kind of statewide body that helps support GME training across our states, along with some other things. So it's a really good report. I recommend you all check it out. It's specifically looking at recommendation 2.2, which is on expanding the number of primary care physician and residency positions. And so all that to say, we have a great need. There's a lot of great opportunities at this point in time, which were not available a decade ago. And so really encourage you all as we go through today to think about how you can play a role in addressing our primary care workforce shortage and capitalize on the opportunities that are currently available. And what's also really exciting about this week, apart from our really good training, is that we are in the middle of Match Week, which many of you know is that process where the residency programs and the actual residents themselves find out where they match, where they will be doing their training in the next several years. And so we are excited for many of our health centers to find out who they will be training over the next several years and see their classes fill up. So with that, any questions before we move on?